Chapter 23, this is drug overdose and toxicity. It's going to be talking about stimulants and depressants that may show up. Your patient may come during an appointment. We've certainly had this in the clinic a few times. It's like how to deal with that if it becomes an emergency. So first we have the stimulants. We're going to talk about those. You have amphetamines. And so they work on the central nervous system. Some examples are dexedrine, Ritalin, Adderall. Phentermine is a diet pill. It's also called an anorexiant drug. They don't really give those out like they used to. They used to be able to go to the doctor and just ask for these diet pills, no big deal, and a person would get the subscription. And in the last, I don't know, 5 years, whatever, they, or maybe even more than that, it has become really difficult because they found that most of these drugs, stimulants, are addictive. And so they are less likely just to hand them out as freely as they once did. So you also have methamphetamine, which is you can take it orally, you can smoke it, or in an IV. So other names for it that they had at the time of the publishing of this book is meth, crack, speed, chalk, ice, glass, crystal. Nowadays, even years after the publishing of this particular copy, I'm sure there's a ton of more names. Dexedrine, Ritalin, and Adderall are used for narcolepsy, which is a person who just can't help but fall asleep. They fall asleep everywhere. And also with a person who has ADHD. So it is a stimulant, of course, to the CNS. You activate the sympathetic nervous system, and this is what gives you your fight or flight response. It results in increased heart rate. So you might have, if you are on amphetamines, you will probably have a prolonged pupil dilation, decreased digestion, your bronchodilation, increased blood flow to the brain and to the skeletal muscles. So it causes a continual release of neurons to exert excitatory effects. So this would be the pupil, where it is not just the pupil is large, but it's extra large. So this is rampant caries from dehydration, xerostomia, and poor oral hygiene. This is what we usually call a meth mouth. So they do not take care of their mouth or their teeth very well. They're prone to want to eat snacky foods and sugary things when they are addicted to these drugs. And they also, at the same time, have dry mouth, not a lot of saliva. And so this is what can happen when you don't have a lot of saliva to buffer the acids off of your enamel. Plus you're dehydrated and dry mouth and have poor oral hygiene to brush it off. And it's really wreaks havoc with the teeth. So here's another picture of a meth mouth. This has a lot of dark stain on it. And when you're on amphetamines, there's an increased intake of refined carbs and high calorie beverages, usually resulting in reduction in the pH. So the pH of your saliva, what is left, has become more acidic, and you have no saliva to buffer that out. And so then you have all these dental caries. Also bruxism, which is the wearing away. They tend to brux their teeth and grind them together, and they have tooth wear. due to the overall increase in energy and neuromuscular abuse. So it can result into something like this. So methamphetamine users, current users, should not receive a local anesthetic with a vasoconstrictor. Oddly, we've had some people, this seems to be quite a while ago, but I mean several years ago, but remember a patient came in and they were asked if they were on any medication, and this gentleman readily gave up that he had used cocaine that morning, and meth, and so he needed a deep cleaning, and we did not want to give him an anesthetic with a vasoconstrictor in it. Many will not be honest about it. If they are using something, if someone is a real addict, you can kind of tell by their actions, and you take a look at their mouth. The mouth can speak 1,000 words. The shape that the mouth is in, you kind of have an idea of what's going on. So if absolutely necessary, they should receive, and they have to have that for a deep cleaning, they should have something with the lowest dose of anesthetic as possible. The epinephrine is the vasoconstrictor and the local anesthetic that we like using, and it helps control bleeding a lot, and is a really good thing. It makes your anesthetic last like 6 times longer than if you don't use a vasoconstrictor in it. So what it can do is cause some palpitations of the heart, and so we do not want someone who already has all this drug effect in their body. We don't want to excite it even more. So and there's other reasons that we'll get into when you have the actual course next term, and about vasoconstrictors. So if you have to use local anesthetic, they need to have the lowest dose possible, or something that does not contain a vasoconstrictor. So enhanced response of the sympathetic autonomic nervous system, which is SANS. And so it results in myocardial ischemia and cardiac dysrhythmias. Remember that cardial is the heart, myo is a muscle. So it results in the heart muscle ischemia. Ischemia is like a blanching of a certain area that is not getting any blood supply. And so it can also cause dysrhythmias and messes with the rhythm of the heartbeat. So it may result in even a hypertensive crisis, and maybe even a myocardial infarction, which of course you know is a heart attack, or even a stroke. The systolic blood pressure could be as high as 200 or more. Signs and symptoms of amphetamine toxicity: euphoria, anorexia, seizures, restlessness, talkativeness, anxiety, agitation, confusion, flushing. They could have diaphoresis, which is sweating, tachycardia, high blood pressure. They could have a stroke, an intracranial hemorrhage, chest pains, heart palpitations, a possible coma, or heart attack. So treatment of amphetamine: if you can tell any one of those things are going on, and you really truly believe that this person is under an amphetamine toxicity, you need to contact EMS and give basic life support, monitor their vital signs every 5 minutes, have someone take down the numbers so you can give it to the EMS when they come. And the EMS is more likely to give them a benzodiazepine, which is a depressant. Some examples would be Valium, or lorazepam is a more popular one these days that they give. And it can be administered to control the agitation, but it needs to be administered by the emergency support system. So what you can do is attempt to cool the skin by spraying lukewarm water or a tepid sponge to the skin and put air fans on them. So they're not so hot. The one thing we don't want to do, which is what they will do in movies once in a while, is they will give an emetic agent. An emesis is another word for vomiting. So an emetic agent is something that will induce vomiting, but it can also induce seizures. Not the emetic agent, but the actual vomiting can induce seizures if they're prone to that. So in the hospital, usually what they'll do is they give them activated charcoal to prevent systemic absorption of the drugs. Activated charcoal is a black powder. They combine that with water to form a slurry, and it works by attraction. It attracts the toxic substance into the charcoal and instead of into your GI tract. So this is in particular if the amphetamine has been oral and it's something that they have ingested. So we're going to talk about the other main stimulant we're going to talk about is cocaine. It is also a central nervous system stimulant, a local anesthetic agent for mucous membranes. So that means is sometimes cocaine, and in fact it was one of the very first local anesthetics, was a form of cocaine. Cocaine goes back pretty far, and the problem is that they used cocaine as a local anesthetic, considered that, but it obviously formed a great addiction to it, so they stopped using it as a local anesthetic. So they don't use it anymore, but it would be accurate to say that cocaine is also a local anesthetic that we no longer use. It is a very potent, the most potent vasoconstrictor that there is. And so what that means, vaso means blood vessels. So it constricts the blood vessels, and sometimes it's used medically still in nasal surgical procedures by ENTs. They may be, when they're doing an operation on the nose, it is, you can remember all those encasal box and plexus, and you can remember the picture where there's just so much vascularity in the nasal cavity, so many vessels and blood vessels. So when they are maybe doing surgical procedures in the nose, sometimes they will use cocaine because you can't get a more strong vasoconstrictor than cocaine. So as a street drug, it can be snorted, smoked. They would call it freebase, crack, rock, snow, coke, blow. It is very rapid acting and very powerful. And like I said before, today there are, I'm sure, a lot of other acronyms for cocaine other than ones you're seeing. You can take cocaine oral or IV, intravascular. What it does also is it prevents the reuptake of dopamine, norepinephrine, and serotonin in our systems. So we release these hormones in order to, as we need them in our body. It's regulated so that we need them. And this prevents the reuptake of that. So dopamine is constantly being released when a person is high on cocaine. And so it produces well-being, euphoria, but it's also going to give the person increased cardiac rate, blood pressure, and body temperature. So intranasal effects are perceived in 3 to 5 minutes. If someone is going to snort cocaine, the peak effect takes 10 to 30 minutes, but it only lasts about an hour. cocaine. So this is what causes people to want to use it again and again and again. And this is what causes such an addiction and a constant searching for this drug by addicts. So oral facial complications from cocaine. Like we said, it is not just a powerful vasoconstrictor, it is the most powerful vasoconstrictor. And so with continued use up the nose, it can lead to necrosis, which is death, and ischemia, which is it will be an area that looks blanched because it has no more blood supply to it, and that's what causes. First, you have ischemia, and then you have necrosis, death of that tissue, because it doesn't have oxygen and it doesn't have nutrients or blood supply. So it can cause a perforation, which is a hole in the nasal septum, is definitely possible. Also, it can cause palatal necrosis and perforation, which means that it can do the same thing and create a hole in the palate of the mouth. I have seen this, maybe 3 or 4 different cases in my entire career, and where there's been a hole in the on the palate, and you can just look right up into the nasal cavity. So it's more likely in women due to more susceptible palatal connective tissue. And so they don't have as strong as connective tissue. So it seems that it can necrose and die more often. But it just so happens that all 4 cases that I have seen in my career have all been men. But chronic sinusitis, these people have with snorting. And they also have a really big decreased sense of smell. So bruxism, also with cocaine, is due to the increased dopamine. They just are high and nervous and on and up all the time, so they're more prone to bruxing their teeth. They can have increased caries due to carbohydrate intake, just like amphetamines. Gingival lesions, when repeatedly applied to the tissues, sometimes people that use cocaine will wet their finger. They put the side of their finger down, get a lot of, pick up a lot of cocaine powder, and then they put it up like into the vestibules of their mouth, either on the maxillary or mandibular, and they just hold it there because it gets into your system really fast there. So if that's done a lot right there, you can have some gingival lesions, some type of lesions when it's repeatedly applied. Vigorous toothbrushing may lead to cervical abrasion, gingival laceration, little cuts on the gingiva, and recession, because they will be brushing everything, all their teeth, too hard. And when they are high on cocaine or amphetamines, they have a delayed healing. So these are some pictures of a hole that was created in the palate, like right here. From this, and here is a picture of a hole in the nasal cavity. So when they breathe air in or whatever, something can just go out the other side. So in the septum, which is the tissue that separates in your nose, the 2 canals, nasal canals, there's just a big hole in it. So this would be just a normal nose, and this is a perforated septum when there is a hole in there and it just kind of dips down because the septum is ruined. This is a person whose complete nasal septum was completely destroyed due to cocaine. And this is a person who was doing so much cocaine for so long up the nose that their nose, the septum, had holes in it, and then the nasal cavity, the nose collapsed. So cocaine and dental hygiene procedures. The local anesthetics with vasoconstrictors are contraindicated. Like I already talked about, you can increase blood pressure substantially, leading to stroke or a heart attack. Cocaine rubbed over the gums can cause numbing and ulcerations. Cocaine is highly acidic. When it's mixed with saliva, it becomes even higher, causing erosion of the teeth. And these people, like we've already talked about, have a huge compulsion to grind or brush their teeth. So signs and symptoms dependent upon tolerance and route of administration. It depends. An IV and smoking produce the highest levels of cocaine and are more likely to have the highest level of toxicity. I would know that. They used to have Coke in a lot of things. They had, I'm sure you've heard about having cocaine in Coca-Cola. And at the turn of the century, and when they realized that this could create addiction, then they stopped putting the cocaine. But they even had cocaine tooth drops and would sell them. Here's for 15 cents, instantaneous cure for toothaches. And they would set up stands. They had a lot of different uses for cocaine. And by the turn of the century, I mean the 1900s, in 1800s into the 1900s. So signs and symptoms of cocaine toxicity: anxiety, seizures, agitation, hyperthermia. Their temperature is higher than normal, so they're going to have a fever, runny, bloody nose possibly, red, watery eyes, hallucinations possibly, arrhythmias, high blood pressure, trouble breathing, etc. So in treatment of cocaine toxicity, if you think someone has a toxic level of cocaine, you've got to contact EMS immediately. So this person needs transportation to a hospital as soon as possible. Until then, you're going to do their basic life support and monitor their vital signs about every 15 minutes. Write them down so you can tell the EMS what's been going on. You want to treat hyperthermia with cooling measures as discussed in amphetamine toxicity. Vomiting should not be induced. It can produce seizures once again, just like your amphetamines. Diazepam and beta blockers, they're more likely to give this in the hospital. So if they ingested somehow this cocaine, then they would want to also give them activated charcoal. They don't give them activated charcoal unless it has been ingested, because that will go straight into the stomach, where anything that's been ingested is going to land. So if it's by another way that they have OD'd on cocaine, they have other measures at the hospital. So now we're going to go to depressants. The two depressants we're going to talk about are opiates and opioids. So opiates and opioids are both derived from a poppy plant juice. It's been around for centuries and centuries. Morphine and codeine are the two main names that are depressants. They have synthetically or man-made produced heroin, oxycodone, and methadone, among others. So the routes of administration are oral, smoking, and IV. They produce depression on the CNS, and that causes sedation, euphoria, and a reduction in pain perception. So when they are on a depressant, they have very constricted pupils, and I mean pinpoint pupils, more than normal. So signs and symptoms of opioid toxicity are lethargy. They're super tired. meiosis, so they can have problems with their eyes, shallow respirations, hypotension, hypothermia. They're going to get really cold and have a low blood pressure, low heartbeat, flaccid muscles, lack of response to external stimulation. A severe overdose can lead to a coma, respiratory depression, and finally death. So treatment, you want to contact EMS immediately. While you're waiting for EMS, basic life support, you can administer 4 to 6 liters a minute of oxygen if they need it. Do not, once again, induce vomiting, whether it is a stimulant or a depressant that someone is has OD'd with. So do not induce vomiting. It's a possible obstruction of the airway. Monitor their vital signs, administration of opioid antagonist, but they give that to them in the hospital. So barbiturates, they now call them benzodiazepines. They were used to be known as barbiturates. They're sedative, hypnotic agents. They're used to be used for insomnia or anxiety. They don't do these anymore so readily, once again, because of the fear of addiction. So barbiturates replaced by benzodiazepine, like phenobarbital is a benzodiazepine, or what used to be a barbiturate. It is also an anticonvulsant. So if someone is convulsing, they're more likely to give them that in the hospital. So it definitely affects the CNS. Like I said on the other slide, it is a depressant. It relieves anxiety. Toxicity of it is always dose dependent. So if you have a little bit, of course, you're not going to be very toxic, but you can also OD and die from it. And pinpoint pupils are another good indication that they have been, that they're high on benzodiazepines or barbiturates, depressants. So treatment of the barbiturate toxicity or benzodiazepine toxicity, once again, the same thing. You're going to contact EMS, give them basic life support while you're waiting for EMS, monitor their vital signs. You want to have some external warming. So you get them a blanket. Remember, on depressants, they're going to get really cold and have low blood pressure. On amphetamine toxicities, they can get really hot. You need to cool them down. So usually they're delivered orally, but you can, if they do give benzodiazepines in the hospital, but they can be given intramuscularly or through an IV. So this would be a barbiturate addiction. She's got really pinpoint with a non-threatening on the street nicknames like Barbs, Bluebirds, Dolls, Downers, Sleepers, Reds and Blues. Barbiturates are anything but. So they're highly addictive as well. So enhancement of the inhibitory neurotransmitter GABA in the CNS is how benzodiazepines work. So it works on inhibiting greatly. Then it's a nerve transmitter, which is called GABA, which is how they work. Produces sedation, hypnosis as anti-anxiety. So signs and symptoms, they're going to be real tired if they've overdosed, slurred speech, ataxia, so they may not have any muscle coordination. They may have mental confusion. They could go into a coma, and respiratory arrest may even occur. So you're going to place them in a supine position to help with their hypotension. and contact EMS. And it's kind of the very same way that you go about it. In the hospital, they may give the benzodiazepine toxic patient activated charcoal if they have ingested this. Flumazenil can be administered as an antidote as it counteracts the sedative effect. So those are some of the things that they can give for that. And this pretty much wraps it up for the entire course. And what you'll be having next is the final, and we'll be going over study guides. I'll give you the study guide, and we'll have a Q&A session about that.